Hey everyone, it's Jess Jersey from the Atlantic General Hospital Foundation. And today we are interviewing someone else from the hospital that we want you to get to know. So hi, Jim. It's nice to see you. Thanks for taking your time to talk to us today.
Right.
Can you introduce yourself and tell us a little bit about your background?
Sure. Absolutely. Thank you. Thank you for the opportunity of having this talk. I am currently the Vice President of Finance, Chief Financial Officer for Atlantic General Hospital, all of our related business units. What that means is that I have responsibility ensuring the financial wherewithal and the assets of our hospital, as well as our business units, including our practices, our cancer center, the foundation, et cetera. I've been in healthcare for about 35 years, a long time, having most of that experience from the Western Pennsylvania market, where I work with small rural hospitals to large academic teaching facilities to practice networks and corporate shared services. On a personal level, I've recently relocated to the area, married to my wife, Jerry, for 34 years, and we have two adult children.
How are you liking it down here? So
Loving it.
Perfect.
Loving the beach vibe, loving the coastal environment, and love the people and the culture here.
Awesome. Well, we're certainly glad to have you here, Jim. And I understand that things in Maryland, as far as the model for healthcare, is different than Western Pennsylvania. Can you elaborate on that a little bit?
Absolutely. There's no question. The model for payments in Maryland is different than it is in other states.
Okay.
Specifically, the hospitals in Maryland are under a regulated rate structure where we receive a capitated or a global amount per revenue per year.
Okay.
What that does, and the way the model is set up, is it's structured so that hospitals can focus on reducing unnecessary clinical utilization, not just churn volume for the sake of volume. What that also does, in the complexities of other markets, is that you remove the obstacle of contracting with payers or cost shifting. So many times you hear about cost shifting in other areas where you're moving services to other payers or other patients, where you don't have that same model happening in Maryland. However, where the complexities and the challenges come about is that Maryland model was based upon patient demographics, is based upon utilization, historical rates. However, as patient complexities change, as technology rises, as inflationary factors of labor, technology, clinical needs, services that are required by our patients in our community change at a rate faster than the inflationary factors of the revenue model, it puts a squeeze on hospitals, and the financial pressures are therefore, a little bit harder to overcome.
So as a not-for-profit hospital, what does that mean as far as where we go looking to maximize every dollar that we do have come into the hospital?
So first and foremost, we will always do what is right for our patients. I've held to the adage for many, many years, is that if we do the right thing for our patients and our associates, the financials will work themselves out. Now, that's easier said than done.
Sure.
Right? And it's a noble effort. But clearly, if we focus on our patients, our associates, and having the right care to the right patient at the right time in the right manner, we will always benefit the patient, and it will work itself out financially.
Well, thank you so much, Jim, for joining us today. Super helpful information.
Thank you.
If you want any other information about the hospital or the foundation, please feel free to reach out to me anytime.